Yeah, can we call Dr. Dipankar? He'll talk about immunology of stromal choroiditis. I mean, we were all scared of white dot syndromes during our PG and fellowship days, and now like it's a little more scary it becomes when you talk about immunology and name change. So we'll see what he says.
Thank you, Dr. Sudarshan. Respected chairpersons, my mentor, Professor JB sir, and all here present. Basically, if you see immunology in stromal choroiditis basically means leakage, sympathetic ophthalmia, the sarcoidosis, TB, or Behçet disease. These are the constellations of syndromic or non-syndromic condition that affect the stroma of the choroid. Second important thing, which choroiditis causes CAB, okay, whether it's a B cell disease or a T cell disease, which are much more prominent. These are some of the queries that we have in our mind when you see pathological slides, when you see about immunological things. Now, I do not have any financial disclosure in this presentation. Now, you see, this is a patient came in COVID with a chronic uveitis. Now, we can well appreciate there is a iris atrophy and a tessellated fundus to mid-dilated pupil. Immediately, you know panuveitis, which is causing probably a leakage in this case, and you can well so in AIOC the KPs in this, and this we published in IGO about the finding here. Now we see the chronicity of the disease in the tessellated fundus, and obviously as Abhilasha showed, imaging is very, very important, and these are the ICGs in different frames showing the activities of the diseases. This is again an incomplete leakage with the fluorescent angiography with a pinpoint dot and lateral fluorosis, and this is a comparative ICG with a fluorescent angiography here with multi-placoid lesions here. Now this is what is very important. No, we can discuss lot of in-depth for immunological aspect, but what is important, let us see one thing. What is the acute disease, what is a chronic disease in choroidal stroma, and what is the T cell and the B cell manifestation of this. Now, in pattern of uveitis from Northeast India, we have seen 14 cases of leakage in 1 year, and 1 case of sympathetic ophthalmia, sarcoidosis 9, and TB choroiditis were not seen. But in 2015, when doing a pattern of uveitis, leakage was 10, sympathetic ophthalmia was 14, sarcoidosis 30, and TB 19 in a population of Northeast India. Now, this is a case when block was sent by JB sir to me to do immunohistochemistry in our lab of a VKH patient. See, VKH we do not get a histopathological sample, but this is a very, very rare, and we have published from the Indian scenario for the first time. You see the stromal choroiditis here, and diffuse plasma lymphocytic cells in the choroid, and these are the patient was previously in that thicyclide was a CNVM, and no, we have demonstrated CNVM in this, and this placoid lesion and the fluid accumulation pockets that are seen in the histopathology here, and we see the photoreceptors degeneration is there. Now, same thing, RP undulation and retinal gliosis was evident in this case. Now, coming to the immunology here, CD3, which is a marker for T cell, was +3, and CD20 was +3. So it is basically a T cell disease that we have seen in this case, and this we have subsequently published in peer-reviewed journal. Another important thing again is seen in this is a case of a sympathetic ophthalmia seen in COVID period, and you see when Professor Biswas published his first paper with cytophotocoagulation inducing a sympathetic ophthalmia, he told that there was pigment migration happens in the site of cytophotocoagulation. And this is the evidence. This patient has a glaucoma in the right eye, and there was a cytophotocoagulation and sun, and you can well appreciate that pigment migration here in this area, So this patient is a sympathetic ophthalmia, and these are all these findings that are showing in this Okay, again the pigment migration being seen here. Now, cytophotocoagulation induced sympathetic ophthalmia in Coats disease that we have also published, which showed a T cell manifestation are much more than B cell manifestation. Remember, for sympathetic ophthalmia, there is a one concept called Dehlen-Fuchs nodule. Dehlen-Fuchs nodule, typically seen in sympathetic ophthalmia, can be seen in VKH, can be seen in sarcoidosis also. But important thing of Dehlen-Fuchs nodules is that they are in acute manifestation. Now we see this case is a chronic manifestation of one sympathetic ophthalmia induced by a vitreoretinal surgery. These RP atrophy are not Dehlen-Fuchs nodules. These are just an RP atrophies. Okay, this we published again as a in young patient, an uncommon entity. Again here T cell disease was much more. Now, sympathetic ophthalmia sometimes can be, it is thought one hypothesis is there whether the trauma can induce such thing. Here is the evidence where sympathetic ophthalmia, again, T cell manifestation was more than and B cell was less in this case. But here is an unusual manifestation of sympathetic ophthalmia. This was seen in a thicycle eye with a chronic involvement, and patient one was on steroid as well as azoran was given in this patient for a long time. Now, when we see immunohistochemistry here, B cell is positive and T cell is less. So you see, when you are giving a medication targeted to T cells, the T cell can be depressed in such situation and B cell can be unaffected. So you do not get a B cell population in those situations, and it can be unchanged or showing an overexpression in some of the situation. Sarcoid is not, this is a lupus perennial and a hard granuloma is seen here. Now we see these are the histopathology where the Schauman's node calcification that can be seen in the inflammation. Again, it's a marker, T cell is positive, B cell is less here. But important thing is to see this is a chronic case of a sympathetic sarcoidosis, and this is again an acute phase of sarcoidosis. And here again the hard granuloma was seen. Now interestingly, this case of sarcoidosis was 20 years. Okay, he was a state bank employee and he was working in the bank and he was having this disease for 20 years. When you see the do the immunohistochemistry here, CD3 was negative while CD20 was positive. Same philosophy acts here in these situations. Yeah, I'm last. Now you see stromal choroiditis. Just to tell you one last this example. This, what do you think? This is a central clearing with this. There is no vitreous cells. Okay. Now this is a case of a CSR. So all stromal choroiditis may not be a immunological or disease or an inflammatory disease. It can be a CSR. So uveitis that I have shown you very basic, which is clinical, pathological and immunological, acute versus chronic. In acute cases, there may be involvement of a T cell manifestation. In chronic cases, there may be a B cell manifestation. More clinical pathological correlation we need to this in this there. So these are the various workshops that has been done here. I like to thank Professor Bishwas sir for sharing the case, Medical Retina Department and Ocular Pathology Laboratory at Sri Shankar Dimnetala, and Professor Narsingh Rao, some slides from his lab. Thank you for patient hearing.
Thank you, sir. That was an excellent talk. And I now invite Dr. Kalpana ma'am to give her comments.
Thank you, Dipankar. Actually, I was actually mesmerized with the photographs and the immunological markers. Actually, more than me, I think Dr. JB is highly qualified to speak on it, and I would like your comments on that.
So, actually, many of the eyes very rarely obtained except for sympathetic ophthalmia. But if you get such eyes, like I got a few days back in Wegener's granulomatosis, which is pain blind eye, we can now with a lot of immunohistochemical marker, you can find out that immunopathogenesis of these diseases, and which helps us to understand. For example, the T cell was not seen in that case of sympathetic ophthalmia, and B cell was seen because the patient was treated, and then that kind of T cell mediated disease was initially, though is conventionally seen, can be seen in the B cell proliferations also, and there is also scope for new learning. I have done some cases of Eales disease, acute retinal necrosis, where I could see that there is, apart from the infection, there is a immune-mediated mechanism like T-cell mediated pathological process is evident. So it indicates that apart from the treating the patients with the antimicrobial like antiviral treatment, we may need to give a oral steroid to control that inflammatory cell infiltration, which might be a combination of the T and B cells.
I just thank you, sir. I would just like to ask Dipankar one question. VKH and sarcoid are very similar in terms of, especially in the chronic form. So, is there anything which, is the pathogenesis the same, or is there something different in this stage? Because both of them have depigmentation, DF nodules.
Yeah, if you see, initial manifestation of VKH is a granulomatous disease. Then sometimes later on it becomes non-granulomatous, and thereafter it becomes a granulomatous form in the chronic stages. But sarcoid, no, because if you see, if sarcoid enters in the chronicity, it does not behave in tri way. It basically a granulomatous disease which can have and sometimes obviously the T cell and B cell may be there, but in sarcoid pathologically in chronic form we get calcification, asteroid body, and Schauman's body that I've shown you is a characteristic. So how to differentiate between a sarcoid granuloma, and sarcoid granuloma is a epithelioid granuloma, which is unlike for the VKH granuloma. So there is a difference between them.
For a non-immunologist, like, see, we were always taught that all these diseases are T-cell based diseases. Yes. I mean, I'm not talking about the same based or something. So we were always told in the direction of treating a T-cell inhibitor like cyclosporin or voclosporin. So as a clinician, like, do you think that we should start thinking of changing the mode of direction of therapy? Does it change anyway in that case?
No, in for example, if you see, to understand anterior uveitis prototype is JIA. Okay, again, JIA is basically a B cell disease. But you see the drug that you are choosing are methotrexate, which is again a mode for the T cells. So these are some tricks even the immunologist may not answer in a straightforward way. Okay, so there are certain things which is very, but once it is a B cell disease, then CD20 and other would be, for example, rituximab adding with a methotrexate would be a better choice in the chronic B cell diseases.
Thank you.